Good morning. We're here at ASH on Monday, and I have with me Graham Jackson, Dr. Graham Jackson. He's at the University of Newcastle upon Tyne, and he is here to talk about a trial near and dear to me, which is the Myeloma XI Trial out of the UK, and the aspect of maintenance therapy and the data that's coming out of that trial in maintenance. So tell us about the research.
Okay, so the Myeloma XI trial was an all-comers trial across the transplant-eligible and the transplant-non-eligible patients. The question we've been talking about at this ASH meeting is around the maintenance randomization. So the transplant-eligible patients were randomized at day 100 post-transplant. The transplant-ineligible patients were randomized at maximum response. Mm-hmm. They were randomized to a 10 milligram a day Revlimid schedule for days 1 to 21 out of a 28-day cycle. And the plan was to give them maintenance until progression. So we enrolled over 1,900 patients onto the study. Over 1,200 in the transplant-eligible arm and over 700 in the older, frailer patients.
Sure.
So the key news, I think, from our data is that the progression-free survival for both groups is very significantly increased. For our transplant-eligible patients, nearly 27 months with very significant hazard ratio. I think in our transplant-ineligible patients, it's around 15 months. I think we very nicely mirror the data that came out from the meta-analysis at last year's ASH and has subsequently been published. With very similar hazard ratios, very similar improvements in progression-free survival. For our transplant-eligible patients, we've also shown a very significant overall survival advantage. At 3 years, the overall survival for the transplant-eligible patients who received Revlimid maintenance was around 88%, whereas for the for the patients who got the observation arm, it was 80%. And that really, again, matches the CALGB data, where almost identical overall survival advantage. So I think our trial, together with the meta-analysis, really answers a lot of questions about Revlimid maintenance in the post-transplant setting. The one area where our data does differ from the meta-analysis and the French and Italian study is that we seem to show from our data, and of course it's small numbers once you get into the high-risk cytogenetic subgroups, but we found that Revlimid in the higher risk patients still gives them an advantage over no maintenance, which is slightly different from the meta-analysis.
Okay. So question about these, this was just Revlimid single agent or lenalidomide single agent. There was no additional any dexamethasone in these patients?
No, there was no dexamethasone. It was Revlimid alone, and as I say, it was the 21 out of 28 day cycle. And it's very interesting then to look at the kind of toxicities, and I think probably that 21-day cycle for us seems to give less hematological toxicity than maybe the 28-day continuous maintenance. I think that's something that's difficult to answer across the studies, but
and I think patients do appreciate a drug holiday, for a week there to recover. Right?
Yeah, I think that week is kind of helpful for them. Yeah.
So Revlimid maintenance has been used for many years, and it's been studied and continues to be studied as far as the impact. As the initiation of Revlimid maintenance years ago was on very little amount of data, but a hunch. So this seems to be confirming that hunch was a good one, and that the data from your study as well as others confirm that using a maintenance strategy with Revlimid in your patients, myeloma patients, is a good strategy to take.
I think so. I think there are obviously still more questions to answer. How long for?
Yeah.
The other data we're presenting today is around minimal residual disease, and one of the neat bits of data that we have today is that even if you achieve MRD negativity by flow, those patients still, so if you have the deepest response, those patients still seem to benefit from a Revlimid maintenance strategy.
It's a very interesting point too, because there was a lot of talk about if you could achieve MRD negativity and not use maintenance if you achieved a certain response. But it sounds like what you're saying is that there still seems to be an advantage.
Well, I think some people might criticize our methodology and that our flow only goes down to a sensitivity of 10 to the minus 4. And obviously newer techniques go down to 10 to the minus 6. But certainly at our MRD negativity levels, those patients still do better on Revlimid than maintenance. So there's some questions that we still need to ask.
So you're from the UK, and I know that access to some of these agents is challenged by by NICE and the availability of drugs to patients. Is Revlimid maintenance available to your patients in the UK?
Not currently, and sadly. I think, however, that the weight of evidence, the overall survival advantage that we see across all the trials now, I think really adds weight and pressure to the funding authorities to allow Revlimid maintenance to be used for our patients. So I hope that it's a game changer.
Yeah, we're hopeful that happens as well. It certainly seems like a step in the right direction.
Fingers crossed.
Thanks for stopping by. Appreciate it.